Welcome back to another Diabetes Canada healthcare provider webinar. My name is Grace Leader. I'm the manager of healthcare provider education, engagement, and professional membership with Diabetes Canada. And I'm very excited to introduce our topic and our speaker for today. Today is all about continuity of care for diabetes and mental health. And our speaker is Julia Bannister, who is a registered and licensed social worker in New Brunswick and Ontario. She holds her master's in adult education from the University of New Brunswick and medical social work from Dalhousie University, has maintained her CDE designation for the past 10 years. Julia's clinical expertise ranges from working in the not-for-profit sector, provincial and federal government health authorities, as well as 25 years in her private practice in Fredericton, New Brunswick. Julia is passionate about the work that she has done for the past 10 years as chair of the mental health section of the professional diabetes educator section of Diabetes Canada, as well as her committee role with the Canadian Certified Diabetes Education Board. And more recently, she has been part of a busy steering committee that helped develop the course content for JDRF's 2023 launch of the Mental Health and Diabetes course. Their work is ongoing, and she invites all diabetes educators and mental health providers to become familiar with the program. Most important, Julia is a person with lived experience in that she is the parent of her 32-year-old son, who at 5 years old was diagnosed with type 1 diabetes. And with the help of their diabetes education team, Julia's son became the first child in Atlantic Canada to go on an insulin pump. While those years were marked by striving and surviving the challenges of living with life with diabetes, Julie is very proud of her son's personal and professional achievements and the major achievements of the diabetes professional community throughout Canada, and she believes in a cure. But until then, Julie continues to work hard to make a difference, however she can, for all Canadians living with diabetes. So without further ado, I'll pass it over to you, Julia.
Thank you, Grace, and thanks for this opportunity to provide this webinar. And I am bringing it to you from the traditional and unceded territory of the Willistic Nation here actually in Fredericton, New Brunswick. And that is where I carry out the majority of my work. So our learning objectives for today, by the end of the webinar, I'm hoping that we'll be able to have the participants shift their thinking away from this concept of referring clients and patients out to mental health professionals and specialists, and more to a concept of referring in to the client and patient circle of care. So it's just a concept. But in order to do that, we probably then need to have a learning objective where we get the participants conceptualizing conversations about referrals that relate to timely access to the best fit mental health resources for the patient. And we'd also like a learning objective to be that the participants are able to actually feel engaged and not solely responsible as their patients and the clients actively seek and work with mental health providers. And that they're able, finally, the last objective is to be able to feel that balance of being supportive in maintaining scope of practice and boundaries when working with patients. So in this webinar, we're not going to cover the how we know when to refer patients out. We'll simply move from the knowledge base that we hope that the diabetes educators have as per the clinical practice guidelines. The following groups of people should be referred out. And that is those who are exhibiting significant distress related to diabetes management, exhibiting persistent fear of hypoglycemia, psychological insulin resistance, and who may be just demonstrating signs and symptoms of depression, anxiety, and eating disorders that could be classified under the psychiatric disorders classification system. It is a challenge to ask diabetes educators to even conceive of developing a solid referral plan when in fact we know that the current health state of affairs in Canada is very cumbersome. There is a lot of backlog of referrals to specialists, to almost any providers right now. All at the same time, we are experiencing evolving and modified ways of delivering care. So that's exciting but challenging for the diabetes educator who could feel pressured when referring to mental health providers. And all at the same time, when they're attempting to refer, patients could actually feel that the process is passing them on from one healthcare provider to the next. So, in navigating this, we really want to encourage healthcare providers, diabetes educators, to set realistic expectations with their patients. And again, to continually use the language difference, shifting our mindset from referring out to mental health professionals to conceptually referring the mental health professionals into the circle of care, and for the diabetes educator to consider their role as central to the client's continuity of care, whether it's at the start of the conversation when they talk about referring to a mental health professional, or anywhere along the journey when the patient is seeking the help or is actually engaged with the mental health provider. And always asking the diabetes educator consider their scope of practice, and that would be really no healthcare professional um, outside of mental health should be diagnosing a mental health condition or prescribing. But we certainly have a lot of screening tools, and you have your clinical judgment. As well, there is a priority for diabetes educators to actually have in in action at all times, operating with their professional duty of care. And that concept is to actually stick with their patients from the beginning of the process to the end. How you do that, though, is something that we're going to discover as we move forward in the webinar. So, conceptualizing this conversation of referral, it might be useful to have a few tools that are screening, such as the PHQ-9s, the GAD-7, the DAS, the DDS. Not all diabetes educators actually use these tools. Some have access to social workers who can actually utilize the tools and screen for the diabetes educator. But either way, we want you to consider having the tools. They are within your scope of practice. If you're not using them, perhaps you could consider using dialogue tools such as the social determinants of health. Make sure that you refer to the Canadian social determinants of health. There are 12 of them. You could even use the Maslow's hierarchy of needs. That is a general psychosocial well being pyramid that you can consider. And it's to guide dialogue, but it may not be diabetes specific enough. So we actually are getting you then to consider if you'd use the Maslow hierarchy of need, there is an adapted one called the Trident hierarchy of need. And we'll look at that in a moment, but always considering the client's history, that they share their own insight to what's going on for them, and trusting that you can use your clinical insight as well. That is not the same as diagnosing. So here it's a little difficult to see, but we do have the Trident model. It's an adaptation of the Maslow's hierarchy of needs. On the left-hand side, you'll see that there are 6 steps to that model, starting from the symptomatic well-being of a patient onto safety, and those are very diabetes specific. And then upward from there, the top 4 are all related to psychosocial needs. If that seems too complex, again, this is something to conceptualize for a conversation. You could go over to the right-hand side and you'll see a 3-tiered trident model, starting with symptomatic well-being, and that's what the patient presents and maybe what you observe, onto the metabolic well-being, and those are the measurable things that a diabetes educator does. And finally, at the top of that pyramid, that's where all the conversation happens about the psychosocial well being of the patient. So, just imagining that you can put that tool in the middle of the table and have a conversation between the two of you. You could even use it as a note taking space and jot down things into the spaces where they apply. It's a great tool to have. It's not diagnostic, it's not even a screening tool, it's a conversation tool. Let's look at the next slide. So, when we do identify some issues that maybe need to be addressed and they may seem outside of your scope of practice, that's the time that you are considering referring to a mental health professional or a specialist. Knowing what resource to access, it becomes one of those questions of, do I know what the resource do I look at the resources first, or do I consider what is the priority here in terms of timeline and the type of referral source I'm looking for? I put the priority in there first, only because we often hear or observe the patient or the client exhibiting some sense of urgency or emergency, or perhaps they keep coming back to saying things like, but I'm not sure if I have a diagnosis of something. So maybe that's optional but desirable. So we want to listen, put our ear to the ground, listening all the way through the conversation to what are the priorities from the client's perspective, but we also want to have the diabetes educator consider what are the priorities from their perspective. So, an emergency priority is just that, it's seek care immediately or as quickly as possible. It involves a resource such as the emergency room, but we know that not everything is an emergency for the emergency room. It may be that it is the self presenting mental health. It could be the after hours mental health services. Some clinics actually do operate later in the day, and that would mean that after hours mental health services would be accessible under emergency. As well, there are times, it's very rare, but there are times when you actually have to bring care to the client in the clinic. And that obviously is when you're calling 911. Imperative priorities are priorities when you know that it's something that needs to be addressed as soon as possible, but it's not an emergency. Resources that you might have for the imperative could be a GP, a nurse practitioner, after hours clinics. If you're in Ontario, Maple actually has a mental health section where you can speak to a physician or a mental health provider, and they do have some diagnostic authority in there and prescribing authority. So that would be more imperative. It's not emergency. Optional but desirable, those would be resources such as the regular daytime mental health clinics. It could be again at your next available appointment with a GP, and perhaps with a social worker through an outpatient clinic. It could even be addictions counseling. Bonus options are just that. It would be great if we could bring in a mental health professional within this circle of care to augment the services, but it's not an emergency and it can be an evolving process. Let's take a look at the next slide and look at resources. So this becomes quite a conundrum for a diabetes educator, and I'd say for many healthcare professionals at this point when they're considering the landscape of mental health services anywhere in the country. So I'm encouraging you to think about the imperatives, then the resources. If we could conceptualize them at a minimal, thinking about internal and external resources. So, internal means within the scope of where you provide diabetes education services. If you're within a larger health authority, you might be within a hospital, you might be at an outpatient clinic. So, there's layers of internal. External resources are external to what you have that immediate access to. And if you think, sometimes at a hospital, if you have an outpatient clinic, but you're in the hospital itself, you might actually be able to walk down with the client, if they're open to it, to the social work department and stand at the front desk and be with them while they book an appointment or request an appointment. So that could be internal. External might be that you are at an outpatient clinic offsite from a hospital and you can't really facilitate the services. So you are actually having the client reach out themselves. So external to your clinic. Local, provincial, national, and even culturally specific options should always be considered, especially when we realize that we do have to think about, what is our primary choice or the first option, but what is an alternative option? So there are many times that we offer now The suicide hotlines, we offer local numbers, provincial numbers, and national numbers. And at times we have to stop and consider, are there culturally preferred options for a patient? So always thinking from local to provincial, national, culturally specific when you're looking at your resources. And of course, within healthcare, we are Canada and we want to make all resources accessible to everyone. So we do stay within the health authorities wherever possible, but there are emerging community and not for profit options that do exist that partner with healthcare authorities. So we want to be mindful of those. A great example might be, although it's not mental health, but they are certainly partners, and that is the pharmacies. There are some pilot pharmacies, and they are community partners. Um, and of course, there is private practice. And as we'll see in a bit, there are a lot more options for private practice, and hopefully, the resources are being made accessible as much as possible for everyone. But we do need to be cognizant that private practice is not for profit. It isn't not for profit, and it is fee for service. But they are still part of our resources, and we need to consider all resources when trying to refer out. I said refer out, refer in. So, i- as an example, when I talked about crisis support lines, an example of a federal one, if you haven't heard about it, it's Government of Canada does have the mental health support Get Help. It is a long um, email address in there, or actually it's a website. So you just might want to think about the name itself, Government of Canada Mental Health Get Support. And how about the 988 Suicide Crisis Helpline? It's really important to make sure that clients and patients walk away with something tangible that is more than one option, especially when considering emergency and suicide. So I always think local, provincial, and national. Next slide. So speaking of national, our partners, um, JDRF has a new, since 2023, mental health and diabetes directory. It's a directory of service providers that has been made available by the long, hard work of JDRF and their steering committee, where they have emerged after developing a course in mental health and diabetes. They have a directory of service providers in each province who have taken training in mental health and diabetes. So they are primarily mental health professionals, but with some diabetes training. They've taken a course that has 6 modules and 3 hours of direct interactive education so that they are a bit more knowledgeable about the diabetes sphere, and you can access that directory and find somebody within your region. They may be from nonprofit, they may be from a health authority, or they may be from private practice. So be sure to check out the directory. And of course, as always, Diabetes Canada maintains a 1-800 number, an email address, and a website where people can call and talk about the resources that they're looking for. They also maintain a very wide range of supports and services in their database. Next slide. So when we're looking at the resources available, there are so many, and about the priorities, we talked about 4 of them. Um, it's difficult sometimes to organize that conversation. So once you start having the conversation, we really encourage the diabetes educator to think about engaging the client in that decision making. And one way to do it, rather than just referring out or in for them, having them do that with you, and start by asking the client to, first of all, describe what is their desired outcome from a referral. What would they hope to emerge at the end of the referral, be it a single session or a few months of services? How would they like to emerge from those services? And once they provide a description, they may need your help, but once they have a description, move on quickly as you can to the next question, which is to ask them which resource out of the ones that you presented, and they would have definitely thought of some too when you're thinking from local to national. Once they've looked at the options and they've looked at the priorities, so for example, if they're saying, I would like to have therapy, but it's not an emergency, we know that we're not referring them to emergency room at a hospital, and we're not referring them to 911. We're bringing 911 in, but we may be referring them to clinics for mental health. Whatever the configuration is, we'd ask you to have them identify what is their preferred resource as they see it based on their description of the desired outcome. Write that down. What is their primary choice of a referral resource? Do be prepared to challenge them if it doesn't match, like the example I gave you. If somebody's saying, I'd like to have some therapy, don't refer them to the hospital emergency room. I understand that people oftentimes think they've tried different options, they haven't been getting traction, and therefore they think that they'll go to the emergency room because they know there are psychiatrists and psychologists that work from there. But that isn't the right place and the right time. So be sure to challenge your clients. It's in collaboration and present to them an alternative from the list of the resources that you have and get them to consider alternatives. We want them to walk away with their preferred referral source and an alternative. Maybe they might have to have three or four, but it's worth matching what is the preferred outcome to the right resource in the right time. Have the client jot down questions that you have thought of that you'd like them to ask when they reach out. If they are age of majority, they will be doing that referral. If you're working from internally and you're able to collaborate in that referral, you may be able to send on a note to the mental health professional. Of course, you do have to have permission of the patient, but you might have some questions and observations that you can share, and you really still want them to develop their list of questions for that referral as well. So that when they call, they're not just asking to book an appointment. They want to know things like, what type of professional would I be seeing? What timeline might I expect to be able to get an initial appointment? And what kinds of services do they offer? What kind of treatment plans do they offer? From there, once you have a clear idea of what they're looking for, what their preferred and appropriate resource is, and the priority, whether it's emergency or optional but desirable, once you've done that and you have actually established an alternative resource with the appropriate timeline, it's time to put it into action. So create an action plan, write the stuff down, because you, depending on your note taking, you might be able to upload it to your clinic notes, and you may be able to print off a copy of this to put into the client's hands so they can walk away, or perhaps you could invite them to take a picture of this section. It is important that they have this detail. So what's the action plan? When will the referral happen? When will you as a clinician provide that referral if you're collaborating, if you're able to do a referral? When will the client reach out themselves? Because if they're of age of majority, they have to present with their own voice to make that request as well. What will be the timeline? When will it be done? And who will follow up with who? That's the last point. Propose a follow up. Request that the client either book another appointment with you. Ask what the option might be if they cancel the appointment. Would it be okay if you followed up with them, or if your clinic followed up with them if an appointment, next clinic appointment doesn't happen? Would that be okay? It's important for you to be able to do that because you do have that responsibility as part of your duty to care, to have details about who you referred to, what the referral was for, when that timeline referral happened, and what the next steps are. So, this is a really quick way to gather all of that information and to make sure you haven't missed anything. And at the same time, provide that client with something tangible to walk away with. Next slide. This could lead to some hesitation from the client. They might already have tried some of these resources and maybe didn't get the results they were hoping for. There are often reasons why. Again, I talked earlier about having the right resources for the right priority and the timelines. Sometimes those things get mixed up and clients come away empty handed. Sometimes they don't get the information correct, that they do have a referral, but they don't know when it will be, or they can see somebody, but maybe it's single session, not ongoing services. So you may find that the client is feeling frustrated, angry. They may feel there's despair setting in because they've tried these things. Perhaps they're feeling ambivalent to the process you just took them through, or they're disengaging. Any of those responses is normal. And you do have resources within your toolkit as a diabetes educator within your scope of practice. You can use the change model of change to help them move through from the first stage of change, that pre-contemplation, to the contemplation stage. You can use cognitive behavioral therapy, the CBT, some of the tools to actually help challenge their irrational thoughts if they're getting quite heated and their emotions and their thoughts are starting to accelerate. You can use some motivational interviewing to help them set those priorities for themselves and embrace the challenge. Those are all within your scope of practice, so feel free to use them. And of course, brush up on the tools. They're available on website at Diabetes Canada. Next slide. The referral roadmap. This is where I say begin and end your process with a mental roadmap. I don't have an image for this, it's not developed at this point. It's a conceptual concept, and we want to begin the conversation with the client and end the conversation with this roadmap. Um, by the time they've conceptualized what they want for care and what those resources are, we know that you've already come up with a statement of a desired outcome. You set a priority. It might be an emergency, or hopefully it's not. They've chosen the resources. You've chosen some resources as well. You've collaborated and kind of triaged what would be the first, the second, and the third option. They have a list of key questions, and you have a list of questions and observations that you could share if you're referring and have that opportunity to collaborate in that referral process. And you have developed an action plan. It's a timely one, a measurable one, a concrete one, and it's wrapped up with some form of follow up that the client patient has agreed to. And I would have more than one option. Next appointment sometimes doesn't happen, and you can feel empowered, the clinic can feel empowered to make that call to the client to find out what happened when they left the office and are they seeking the care because they've given you permission. So it's a conceptual referral roadmap. It begins the dialogue, it ends the dialogue. And this is all within your scope of practice as a diabetes educator and within the mental health scheme of the patient's overall care. Referring in, not referring out. It's a mind shift, but I think it's a pivotal one. So I'm handing it back to you, Grace. Thank you very much.
Thank you so much, Julia. That was great. Before we end the webinar, I just have a few things to note. All of our past webinars are available at guidelines.diabetes.ca/webinars, as well as the other two webinars in this mental health series, if you have not watched them, on disordered eating, as well as one on diabetes distress. You can go watch those now. And there's a link to our podcast where there are episodes on each of those topics, as well as this one as well. Please fill out the survey in the show, in the YouTube link. It helps us improve our webinars for the future. And you should consider becoming a Diabetes Canada professional member. Members get a discount to the Diabetes Canada Professional Conference. You get online and mailed versions of the Canadian Journal of Diabetes, as well as online versions of the Diabetes Communicator. You get access to our online community as well. So you can consider becoming a member at diabetes.ca/membership. And of course, so professional members can continue the conversation about this topic at community.diabetes.ca. Also, if you enjoyed today's presentation, consider making a donation, www.diabetes.ca/donate. Joy, I just want to thank you again for doing this presentation. I think it's very important information. I think I firmly believe in, as someone living with type 1 diabetes, that I love the idea of referring in instead of referring out, and making sure there's continuity of care for people living with diabetes who are also dealing with mental health concerns. So thank you so much, Julia.
Thank you, Grace.
All right.
Bye bye.
Thanks everyone for watching, and we'll see you next time.